Hello everyone, this is Alraies from CVI 2022 in Denver, Colorado. I'm privileged today to have Dr. Tim Henry, past president of SCAI, and he's going to talk to us about outside of hospital cardiac arrest. Dr. Henry, always a pleasure to see you.
Yeah, Chadi, thank you. First of all, it's great to be here, and this is a really vibrant conference. So I really congratulate Mayday and Manos and Paul. We really have done a fantastic job of putting
it's
on
very engaging and short, yeah.
Yeah.
So outside hospital arrest, it's always a big debate between us interventionists and the ER and whether to bring the patient to the cath lab or not.
Yeah.
And I know you're an expert in that space, multiple studies done before, but tell us exactly how to can handle this.
Yeah, so first of all, I think out-of-hospital cardiac arrest is still a very challenging problem for us, right? So several 100,000 patients a year die of out-of-hospital cardiac arrest. But I think, and what I'm going to talk about tomorrow are contemporary issues. And I think there's really 4 people should know about. So number 1, it's important that you divide out-of-hospital cardiac arrest into patients with ST elevation and without ST elevation. And it's a little more complicated than that, because if you do an EKG of someone post-arrest, about a third will have ST elevation, about a third will be normal, and then about a third will be post-arrest, right?
Yes.
Left bundle, atrial fibrillation. So, but let's take the group that has no ST elevation, a normal EKG. And we get called at 2 o'clock in the morning, should we take this patient to the cath lab? Cardiac arrest, normal EKG. So now we have 2 really well done randomized trials, COACT and Tomahawk, that show that if you don't have ST elevation, you don't have to go to the cath lab. There's no benefit of going at 2 o'clock. So if a person recovers 2 or 3 days later, you can go to the cath lab. Yeah. Some patients will, but there's no reason. So that's a really important point.
And very important.
Okay? Yeah. And I think it's settled now. 2 really well done trials. So number 1. Number 2, a higher risk group of people. What about the patients that have ongoing arrest and no return of spontaneous circulation? So these are people having ongoing CPR.
Yeah.
So these would be, if you stop CPR, they'll die, right?
Yeah.
So there's a randomized trial that published in Lancet last year where they randomized people to ongoing arrest, to ECMO, or stopping CPR. And these are selected people. They're young, it's not for the faint of heart, but the patients who had ECMO, 45% lived, and the patients who stopped CPR, not unexpectedly, 100% died. So that's kind of a new frontier, right? And then another important issue. A third important issue, I think, is the interaction of cardiogenic shock and cardiac arrest. So,
which is very common.
It's very common. Yeah. So 50% of people with cardiogenic shock will have a cardiac arrest. Mm-hmm. And those patients are the highest risk. So in our STEMI data, mortality if you have both is about 45%. If you have just cardiogenic shock, it's about 25%. If you have just cardiac arrest, it's about 20%. So the interaction is especially bad. And why does that matter? Because if you're going to put people in a randomized trial, like say for ECMO or Impella, right? But half the people had a cardiac arrest, the reason they die is brain death, not pump failure, right? Exactly. So it's a really important point, and so it's an important thing to think about in trial design and to understand that this is a really important action. And then the last one I won't have an answer for, but that's hypothermia. So what should we do with hypothermia? So the guidelines say we should do hypothermia. Now there's been a series of trials that show that hypothermia to 32 degrees is not better than going to 36. But that doesn't mean you shouldn't do hypothermia, because both groups got it. So I think this is evolving about the benefits of hypothermia. And I think most people that have in their standardized program are still doing it, but not cooling as far.
Absolutely. So now this is from all interventional studies. Is there a collaborative work between emergency room and interventional cardiology to bring this new concepts and understanding of arrest so both society understand how to handle these patients?
Yeah, so, and I will tell you another background of cardiac arrest. If you look back in, until like 15 years ago, the survival was about 10%. But now these randomized trials, it's up to about 50%. And that's reflective of better overall care, the chain of survival, right?
Yes, yes.
So more AEDs, better CPR, faster people to, the emergency department and care that, definitive care. So we've made overall care, and that's a testimony to the EMS, to the emergency department, and cardiologists working together.
Yeah. Well, this was one of the best synopsis or overview of cardiac arrest management I have ever had. This interview, I think, was very impactful to understand the 4 domains that you just covered, Dr. Henry. Thank you so much for your time and for your insight.
Delighted to be here.
Yeah, and please watch this video and others on CVI YouTube channel. This is Chadi from CVI 22 in Denver, Colorado. Dr. Henry, thanks again.
All right, thank you.